afternoon, everyone. I would like to welcome you all for this lovely session about the training. Our first speaker is Professor Marilyn Gusek. She has done a lot of work for the whole universities, all universities in Egypt. She did training for the assessors who are going to be responsible in their universities for training assessors to evaluate the interns in their 2 year of training. So she's going to talk to us about this experience, and thank you for being with us, Professor Marilyn.
Thank you so much, and good afternoon, everyone. It's truly an honor. I wish I could be there in person, but I'm really glad that I was able to participate virtually with you and to continue our conversation around this important topic. So I'm going to share some slides and hopefully go over a little bit about some of the key things that we all learned about together as the importance of creating a professional development program for assessors to prepare them especially to implement new and changing paradigms in medical education. So let me pull up my slides. So again, what I hope to focus on in these few minutes of conversation are the sort of approach that we did together in thinking about how to train assessors in a competency-based program of assessment. And as you can see, I use this same sort of picture in many of my sessions because this is really remembering that assessment is such an important aspect of the work that we do with learners as teachers, but often an area of development that we all need to continue to advance our skills in, especially as new paradigms for assessment become a part of what we do every day. So just to provide an overview, I had the opportunity to work both virtually and then in person with many of you there and then at other universities to think about the various components of professional development that one should consider as you prepare assessors in a new program of assessment. So starting first with some principles of competency-based education and assessment, we work through workplace-based assessment, then the use of entrustable professional activities as a framework for assessments, and how through these assessments as teachers, we are promoting learners' clinical development. We also talked about shifting a little bit the way we do feedback and actually work with learners to use a coaching approach, and then talked about the data that we collect and how to look at that data with our learners, how to remediate those learners that were not yet meeting expectations, and then how to actually work together and have a group of people participate in the aggregation of assessment data in order to make decisions about learners' progress. And then, of course, the importance of using data also for our own program evaluation to know how well we are implementing as intended our program of assessment and how well it is providing the information we need about learners' abilities and their development of competence. So again, in thinking about competency-based education, the importance of helping assessors remember that it's not one assessment, but actually multiple assessments that need to be used to measure competence, and that these assessments need to have high quality quantitative measures as well as qualitative information, narrative data, and that again, competence decisions are not just made at the end of a program of training, but rather throughout the program to understand learners' development through the program. And again, I bring this up now to remember that training of assessors who play different roles throughout this process is critical in thinking about training our assessors. So again, these are the principles of programmatic assessment, creating opportunities for learners to be engaged in a clinical environment in authentic clinical care, using that competency-based framework for our assessment and sampling their performance across multiple different contexts in order to, again, give them feedback so that they can continue to develop and we can individualize their learning, but also enable them to have a reflective ability to look at their own abilities over time so that they can make learning plans to continue to get better with guidance from their supervisors. And again, as assessors, we can aggregate that data to make summative decisions. So again, these principles are important as you think about the different stages of training that are required for assessors throughout the program. This was highlighted again in thinking about CBME and the implementation of programmatic approaches to assessment. And I want to focus initially again on thinking about the professional development to collect the assessment data and how critical it is to, again, prepare assessors across those multiple contexts, disciplines, and conditions in order to gather the information we need. So why think about this? Well, this is really a change from moving from a test, if you will, or even a simulated test like an OSCE or an OSPE or performance of skills to the real world, so that we can actually see how learners are doing the things that we're assessing them in their care of patients, especially when we're talking about learners at the level of interns. So again, using workplace-based assessments or assessments within the clinical environment addresses some of the limitations that simulated assessment have. It's real life, and it's actually assessing them doing those real skills in real life. It's an opportunity to give them feedback, again, because we're watching them do what we expect them to be able to do in the clinical context. And that's important, again, for the feedback that we provide to them, which has an educational effect, but also important as we look at incorporating, again, aggregated data into the evaluation of our programs, to make sure that our programs are again, teaching the learners what they need to do and giving them enough opportunities for assessment. So what are the critical components of workplace-based assessment, and why am I pointing this out? It's important to point this out because these are the things, again, in helping our assessors or the supervisors be able to do assessments. We have to help them learn how to do direct observation of learners. We have to help them understand what the performance expectations are and the criteria for assessment. And our learners should understand that as well. And that highlights the importance of thinking about the training necessary for learners when you're implementing a new system of assessment, so they understand what is expected of them. Consistent application of assessment criteria and training assessors to be consistent in their application of criteria pays attention to the risks that are just a part of being a human being and a human being as a supervisor. And that is that we all have cognitive, implicit, and some systematic biases that can change our impressions rather than focus on what we're actually observing. And again, another skill to think about in helping assessors is to be able to give good, high quality feedback based on the criteria for assessment that allow learners to continue to progress. So again, professional development, the key tool in all of this to build skills. I will also make the argument that it's also a mechanism to bring people together to promote buy-in for a new system of assessment. And I know you're going to hear a talk later about change and sometimes the resistance that you can face in large change efforts like you're doing. But also importantly, that this bringing people together for trainings, whether that be virtually or in person, is a way to build a community of practice. Again, a group of like-minded people who are partnering in this initiative. So again, we talked a lot during our program about entrustable professional activities. And as you'll see from this article and the core components, many of these that were illuminated through the implementation of competency-based assessment are the same principles here. Workplace-based assessment, the use of qualitative data in addition to quantitative data. And then also, as we'll talk about in another slide, the importance of developing a group shared mental model, not only around assessment, but about how you aggregate those assessment data into to make a decision about learners' performance. So again, in professional development sessions for assessors, as supervisors need to prepare to do those effective observations of learners in authentic workplace settings. They need to be using a shared mental model because they need to understand the performance expectations and how to apply the criteria, and then how to integrate that into an ad hoc or in the moment decision or assessment about the learner. And again, it's not only a decision that they may use in their ongoing individualized work with the learner, but information that will be reported back to the learner and to the program so that the program itself knows how the learner is progressing. So again, thinking about our clinical training experiences and how to implement workplace-based assessments, how to help assessors do those assessments and then coach the trainee so the trainee understands the results of the assessment, and the supervisor and trainee can work together to say what is needed for you to continue to learn and develop. Those are intermediate assessments that ultimately, again, provide over time an aggregation of a small group of assessments to make a decision about maybe passing this rotation or passing to the next phase of the internship, but that ultimately by the end of the internship, being able to have enough data to make a decision about an intern's competency. And so let's focus a little bit about the importance of, again, professional development in helping the group that is charged with making that sort of more summative decision, meaning that, again, not just at the end of the training program, but during key times during the training program, to combine assessments, to interpret the assessment data in a meaningful way and using a shared mental model and established set of criteria so that they can make decisions about progress through the educational program and ultimately about completion of the educational program that are of high quality and can be of high reliability and validity, meaning that we know that this learner is ready for the next phase of what's expected for them in the next phase of their, careers as physicians. So again, preparing that group is important, and you'll see right at the top of the slide, the group of faculty who are charged with making these decisions, again, during the educational program and ultimately at the end, need training. They need to meet regularly so that they can look at the status of each learner. And part of that meeting regularly is building that community of practice among that group and also a sort of quality assurance around how that group is making decisions. That group can also, again, provide feedback back to the learner that's intermediate that allows that learner's education through feedback and coaching to continue to develop. This group is also charged with integrating longitudinal data, including measuring, again, how trustworthy that data is. And again, how trustworthy the learner is that they too are making progress towards their individual learning plan. And again, this group also needs to incorporate data from multiple different assessors, all of whom have been trained, and interpret and aggregate that to make a summative decision. So just to remember why this is important and why you're working so hard. And I love this quote. So if educators want learners to find meaning in their training, we must guide, observe, and monitor them to the point of entrustment, and then actually show our trust by giving them the responsibilities that we know they are capable of doing in patient care. But I think most importantly, remembering that this is for our patients and bringing the patients into this assessment question is really marrying both our educational and our responsibilities to patients in the community and our healthcare responsibilities. So again, watching what learners do, knowing through those assessments that they're ready to take on the responsibility of patient care, and being able to ensure that our patients know that our learners are able to do that. So again, professional development. I just want to say throughout this process and throughout the opportunity I've had to work with you all, what I've tried to sort of emphasize is how important this is as a tool to build skills. But I will also say, and as you'll talk about in future presentations today, it's a way to promote that buy-in, to get, again, all of our colleagues together with us on this journey and to build a community of practice that continues to learn from and with each other as we implement new initiatives in medical education. So I will stop there. Thank you very much for, again, this opportunity to talk with you this morning and hopefully have a rapid sort of run through all the work we've done and hopefully start the day with a good conversation. So I think I have a few minutes for questions, if that's okay.
Do we have any questions or comments? Thank you again for your presentation. It was lovely and focused and to the point. We enjoyed it. Thank you. Okay.
I would like to invite our second speaker, Professor Dr. Ahmed Makhlouf, the Dean of the Faculty of Medicine, Badri University, and he's also the key person in the program for the internship training with a lovely team. He's the one who created the program for the internship training, and he's going to give us an insight about the program. Thank you, Doctor.
السلايدز حركه ازاي؟ حركه السلايدز ازاي؟
هيجيبوا لحضرتك.
أقول نيكست. طب ارجعي بقى من الأول. تمام، شكرا. Thank for inviting me to this session. دكتورة رانيا ودكتورة سهى ودكتور عمرو. ودي مش أول مرة إن أنا أجي في المؤتمر عين شمس، جيت برضو السنة اللي فاتت واللي قبليها. العنوان New Trends and the Future of Postgraduate Medical Education. We can claim إنه بالنسبة للundergraduate at least in the contexts of concepts and trial of implementation, there is increasing number of staff who now understand and try to implement most of the trends and concepts of undergraduate medical education. In Egypt, this is not the case in postgraduate. Starting from the internship and especially the postgraduate, especially the clinical degrees of or clinical specialties. For glad acceptance, change your attitude, and to change your attitude, change your concepts. The aim is to raise 3 questions. What are the top trends shaping current postgraduate medical education? And what is the expected biggest challenge in facing these trends? And what does the future worldwide of postgraduate medical education? دي السنتر أو الكور سلايد of my talk. إنه التوب trends shaping postgraduate medical education can be presented in terms of 4 themes and 2 trends for each theme. The themes are postgraduate medical curriculum, the application of learning technologies, the assessment of competence, and professionalism in medical education. When we are talking about the curriculum, we are talking about outcome or competency-based and the unitary approach to medical education, as we will see, the use of simulators and e-learning. The assessment of competence is far different from the classic assessment. Professionalism in medical education in terms of training the trainer who are supervisors of the trainee, and the best evidence medical education. To avoid a growing gap developing between what is possible educationally, what is optimum, and what is delivered, such sessions should be repeated to consider that you shouldn't miss the future. خلينا نتكلم لو بالعربي. احنا كلنا للأسف بنعتبر انه ما فعل بنا في التريننج والاسسمنت هو الايديال، وبنقيسه هو ده الستاندرد، واي حاجه غير كده يبقى هو ده كلام مش مظبوط. ده مش هيخلينا لا نشوف المستقبل واللويالتي او لويالتي تو يبقى تمام. I will speak in English. It's important that loyalty to the past does not cloud our minds or prevent us from sharing in the joy and satisfaction with what will be possible in the years ahead if we allow to happen. The comfort of inertia is not a good option. We need to face up to the annoyance, excitement, if we see it as such of action. We have to always look forward. Everything is changing, including the standards of education. There are 3 pointers related to training, especially in emergency medicine: the pressure of time, the balance between the workload and the training, the quality issues relating to the effective selection and training of educational supervisors, this is very important, and the need to identify and develop strict and good performance and outcome measures. We will start by the first theme, which is the competency-based education and competency-based curriculum. Here, what's new is that it's not merely knowledge, it's not even merely skills, it's not even merely attitudes, but it is a complex competence addressed by three main components: the professional knowledge, the professional skills, and the professional values and behaviors, including research, education and training, safeguarding vulnerable groups, patient safety and quality improvement, leadership and team working, health promotion and illness prevention. I want you to get the message from this talk is to refer back to what we are doing in assessment and what of these elements we concentrate and address and what we neglect. We will find a big gap between the what we address and what we should address in terms of training and assessment. All of us, we know that there is a shift even in defining the role of teacher, and this applies more important in postgraduate training. It will not be just the teacher should not be only information provider, not only coach, but he should be a facilitator, mentor, developer and implementer of a definite curriculum, assessor, and not only assessor, but diagnostician of the curriculum itself, whether it is valid or not, role model, and this is very important, as teacher and practitioner, manager and leader, even for a small unit, for a clinic, outpatient clinic, scholar and researcher, and professional. The vision is not to miss that the medical education is a journey, it's a continuous journey, and there should be a very clear link between the undergraduate component and postgraduate component, residence training, and in between the internship, which is now 2 years in Egypt. We have the NARS, all of you should be aware of this, which are the competences that the student should achieve at the end of graduation or at the graduation from the undergraduate medical schools. And we also have now the competences of the medical internship of the 2 years, and we hope to standardize also the core competences of postgraduate. As you see, the three components can be linked easily together. We did this already in the medical internship program. The competences, the entrustable professional activities, as we will see, are very linked to the NARS of the undergraduate, and this hopefully should be the case in the postgraduate when we are planning. We should be aware that in postgraduate training, we shouldn't depend only on competences, but we should transfer these competences into what we call entrustable professional activities in order to translate these competences into real practice tasks or real practice performance. So it's a measurable task representing expectations and examples of clinical and professional achievement of the trainee, reflecting the competences which should be stated before. So the entrustable professional activities are observable, measurable, work-based professional practices that can be entrusted to a sufficiently competent learner or professional. I can say that this at the level of, for example, medical intern, or a level of master degree, or level of consultant, can be able to for example, obtain a history, interpret investigations, do something at the level required, trustably. I am confident that he can do this in real practice and in real situations. So it's a valuable way to conduct competency-based medical education. We can say safely that without entrustable professional activities defined for training and for assessment, we cannot assume that we are applying competence-based education, especially in postgraduate real practice term. So again, the communication should be clear. Another vision detailing what we mean by competency-based education in the postgraduate is that there are two components of professional capabilities or professional competences, generic for any specialty and specific for each specialty. I think here we are missing the generic capabilities or descriptors or EPA. We are concentrating more on those related to the clinical specialty. The generic professional capabilities include professional values and behaviors, attitudes, professional skills and professional knowledge, and there is no time to tell you that for each element there are now standard ways to learn and to assess. One of the good things for surgeons is that there are what we call non-surgical skills for surgeons. This term, learn, train, and assess the performance of doctors in the theater away from the skills and knowledge, away even from the technical skills. They call them non-technical or non-surgical skills for surgeons. Whether he can communicate with the nurse, with the other staffs, whether he assemble the all situation, the choice of the patient, and so on. A lot of elements. His voice is low, is not irritable, and all things should be evaluated and repeatedly to train them to be professional. And that's why we call them professional skills and professional values and behaviors. Of course, for clinical related specialties, the things are traditional, but for generic professional capabilities, as I mentioned, this is example of professional skills, practical skills, communication and interpersonal, dealing with complexity and uncertainty, clinical skills, history taking, of course, consent, human interventions, prescribing medication safely, and using medical advices safely. I will jump on this because these are normal. These are the examples of entrustable professional activities that can be applied for even the consultant level for training certification for consultant, but we state them for at the level of medical internship, starting from obtaining history, diagnostic, differential diagnosis, management plan, oral and written reports, perform general procedures of a physician, educating patients, obtaining consent, communicating, transitions of the care, infection control, collaboration as a team, taking care of himself, system failures or malpractice identification, quality improvement, educational activities, writing medico-legal reports, applying evidence-based steps. All these, you will find that the first 10 we do it, but the next 10 we are neglecting or not concentrating on. The application of learning technologies, we shouldn't miss the use of simulators. This is very important at any level of training, even MD or consultant training, because it gives a chance for effective feedback, repetitive practice, range of difficulty, multiple learning strategies, clinical variation, controlled environment, and individualized learning before translating this into real practice. So the use of simulators is not a fun and is not just that to say that I have simulators, but it's very important component in postgraduate training. The same for e-learning. أنا مستأذن هتديني دقيقتين بس بالضبط. E-learning also is not just a passing fad, but it's not only about knowledge transfer, but it has different functions which should be used. The most important element and the last element is how to assess all these entrustable professional activities and professional capabilities. It will not be done completely by the tradition. As we saw, this important pyramid, which is the clinical competence, starts from know-how, show-how. The most important now in postgraduate is to test the does element of the pyramid, of Miller pyramid, is by direct observation of performance using workplace-based assessment. And this slide shows you is observation of clinical activities by what we call DOPS or mini-6, discussion of clinical cases and the high cognition interpretation of patient case by case-based discussion, and the feedback from peers, co-workers and patients, as I mentioned, which is called mini-peer assessment or team-based assessment or non-technical skills. Direct observation of non-clinical skills and documentation of work experience through portfolio, not logbox. This is applied for testing the professional behaviors. Can I ask you what is the difference between logbook and portfolio for the junior staff? What's the difference between logbook and portfolio? Why I state that portfolio, not logbooks? Because portfolio adds the reflective practice, and this reflective practice is very important. It ensures bilateral interaction between the learner and the trainer, and giving him feedback and giving me as a trainer feedback about the process. So portfolio is very important. It is very important also for self-assessment, which is very important also as a component for training the postgraduate trainee. Lastly, we have to use the evidence-based medical education to train the trainers. What we mean in postgraduate by trainer, senior residents, assistant lecturers, and so on. All are trainers in our clinical experience situation. Finally, there is a need for a strategic vision of the future for postgraduate medical education. مش هتكلم بقى على قصة البورد وكده لأنها قصة political شوية، لكن we have to have a CCT component in our degrees adopted by our departments. Not only master degree and a PhD or MD, but we have to give the trainer a CCT, Certificate of Completion of Training, stated in it all what we say in terms of workplace-based training and assessment. The sense of danger must not disappear. The way is certainly both short and steep. However, gradual it looks from here. Look if you like, but you will have to leap, and thank you.
Thank you, Professor Ahmed Makhlouf, for this presentation. I can open the floor now for any questions or clarification. Any questions? Okay, now we. Okay.
Thank you, Professor Ahmed, for the very nice talk. I'm Professor Dia Marzouk, former head of Family Medicine Department in Ain Shams. You know, we are a postgraduate department, So I used to use, templates because we have rotations of our trainees in 13 departments. We used to have a template, one template for the evaluators to write about what is the actual training of these trainees. And for example, if the rotation is 2 months, they observe them all through the 2 months, and they give us evaluation. But maybe this was what is my activity to do, but it's not all the department's policy. But they should, if the student knows that he's going to be evaluated continuously with the evaluator, I think he will do his best to be put in his portfolio for the continuous medical education. This is my comment. So persistence is needed. Thank you.
We are trying, and I am not sure we can achieve this, in the medical sector committee of the Supreme Council of Egyptian Universities, is to include the activities of lecturer, assistant lecturer, and the activities and their involvement in postgraduate training and assessment in the promotion laws by clear evidence. I hope that this can be a good way to ensure some seriousness of this training and assessment.
You have comment? Okay, thank you, Dr. Ahmed. I have one more comment. You mentioned that a portfolio is the essential part of the training, and the reflection is a major part of the portfolio. لكن دايما بيبقى في misunderstanding. What is reflection? What I have to do? The concept of reflection is not well, عايزة أقول not well structured في the student mind, عشان حتى لما يبقى post graduate أقول له اعمل reflection. What I have to do. في أنا قصدي إن هم مش عارفين يعني إيه reflection. دايما بيبقى في misunderstanding.
There is difficulty because the teacher himself does not know, and he's not trained about how to reflect. The simplest equation, which I myself tested, is that in Egypt we like everything to be well formulated as a template based. So there are basically 3 questions after, for example, 1 week of studying, or after operation, or after visiting outpatient clinic. What went go, what went bad, and what are your suggestions to improve? If you are planned now to learn, yes, this is my. Of course, I didn't invent this. There are references to tell this, but I just tried to simplify and to make it as template-based as possible, because this suits us in order to learn the students under and postgraduate. You are now planned to learn how to take history, or how to give intramuscular injection on a model. So what went well, what went bad, for example, I didn't do it by myself, for example, and what's your suggestions? And you will find that this is, most literature says that you should allow the student to reflect and don't comment on his bad reflection. Try to do, because this will train him and encourage him to tell this.
So it's answered, we put it in a structured way, structured reflection, semi-structured. Thank you so much. Now, عشان أقدم
مفيش كلام كتير يتقال يعني.
Now we move to the next presentation by Professor Dr. Marwa Al-Deeb, Professor of Pediatrics, the Director of Interns Training at Ain Shams University Hospital.
Okay, thank you, Dr. Rania. Thank you, everyone, for attending. It looks like I have to speak in English most of the time, but some Arabic words might slip. they're not very important. Okay, my name is Marwa Adib. I'm professor of pediatric gastroenterology at Ain Shams University. Recently, I'm being the program director of the MI training program since September 2023. So I love to start with this slide because can anyone think of a reason why did I start with this slide?
Reflect on the
Reflect on the slide. It's the gap. It's the gap that we usually see between medical education principles and training and the hands-on training. There is always a gap that needs to be filled, and if you look at this gap, you will find these are the basic main corners of this gap. The clinical skills part, because usually the medical education tend to give us a lot of theoretical knowledge. Sometimes when you really want to apply this on the hands-on training part, you're missing a lot. You're not being taught this before. The other thing is the doctor or the physician-patient communication. No one tells us about this in our undergraduate courses. So again, when you are actually in the hospital, you are faced by a lot of malpractice or mispractice or difficult situation just because you missed the communication part. And the third thing that the medical education does not actually stress on is the pace by which the technology and innovation is far ahead from the what we learn. So we learned today that the complete blood picture is the most important investigation for so-and-so. And then what's actually happening is that technology and research and advances are way in front of us. We are missing the space. And fourth is the interdisciplinary collaboration. And I had to mark this because I know now with the integrated programs, this gap might be a little bit bridged, but still it is a gap between the education and the training. And this is exactly what the new MI training program is trying to fulfill. It's trying to bridge this gap between the solid principles of medical education and the principles of, or the essentials of the hospital training. This program, Dr. Ahmed مشي بس هو حقيقة سهل عليا حاجات كتير because the benchmark of this program is the GMC for the UK Foundation program. We didn't invent a lot in it as a start, and it starts with defining who is the medical intern. The medical intern is someone who graduated medical school, but he is in training. He is not responsible. He needs supervision and direction and hands-on training. He needs a mentor or a supervisor, as Dr. Yasser. Okay. I'm happy to see a lot of the members of the training committee. So this whole training program aims at facilitating the transition of the medical intern or the medical student to a qualified doctor who is accountable, capable, compassionate, all the principles of Hippocrates that we say. The principle is the entrustable professional activity, just as Dr. Ahmed referred to, a specific measurable task and responsibility that I want my intern to be entrusted to do in his practice with some degree or in appropriate degree of supervision. Our MI program has 20 EPAs. Dr. Ahmed mentioned them quickly. I will try to fit them in the gap. So if you can see, the clinical skill, which we're missing in the medical education part, are covered in the EPAs from 1 to 9 and 13, basically history-taking examination, setting a differential diagnosis, interpreting investigations. Then physician-patient communication, EPA 10 to 12 and 19. I myself don't memorize them all, but they are filling the gap. Technology and innovation 20, interdisciplinary collaboration from 14 to 18. So as you can see, from 1 to 20, our EPAs are trying to bridge this gap to make it easier for the intern to practice medicine, not only the solid knowledge. It's 2 years. We are here in MI1. 12 months, rotations divided, 4 rotations for the major 4 disciplines, general surgery, obs and gynae, internal medicine, and pediatrics. And then, inshallah, when they graduate the first year, they will go into the second year, again, the 12-month, but divided, 2 months anesthesia, psychiatry, family medicine, emergency medicine, whether surgical or internal medicine, and then 4 months for the specialties, and they get to choose the specialties without compelling us as a faculty that they should practice this later on. Just practice the specialty they would like. So this is the structure, and Dr. Ahmed referred to this: workplace-based training and assessment, direct learning, self-directed learning and development, and the most important part is recording the learning in the portfolio. So how did we get started in Ain Shams University? We get started in September 2023 by this circular from the Dean of the Faculty. We created the training committee. دكتور علي، دكتور رانيا، دكتور سهى طبعا، دكتور مصطفى مش موجود، دكتور دينا، يعني we have very big names ما شاء الله يعني very supportive. And then we start building the team. The team starts with the educational coordinator in each department. هو ده the boss, يعني the plan كلها from the educational coordinator, supervision and planning of all educational and training activity. Clinical supervisor 1 to 25, and we have one clinical supervisor for every 21 of the interns, and these are as per the council. يعني. He followed the progress, put the plans. صح? You're doing that. Thank you. And then we have one trainer for every 10 interns, and this trainer يعني he's shadowing the intern all through the time, day-to-day training progress, and he also do a lot of the formative assessments during the rotation. يعني I'll go through the educational coordinators. They're very much يعني prestigious, esteemed professor, Professor Muhammad Bahia, General Surgery, Professor Zainab, Internal Medicine, Professor Walid, والحاجة بقى Professor Walid of Singaini. They're all يعني very passionate, very dedicated. يعني I'm lucky to have them in the team. Professor Maha Zakaria from the pediatric department. We start piloting this program. We started actually in March 2024. لكن we started piloting as per the ما اعرفش لجنة القطاع يعني ايه بالانجلش, I'm sorry, but as per the committee, we start piloting in September. We were supposed to end it in December, but we were very happy with it, so we continued in Jan and February as well. Our target was the interns of 6+1, and these are the main pillars of our pilot plan. Faculty development, this was our major concern, because we as faculty members, we were new to this, so we invested more in the faculty development and training. We started implementation, receiving feedbacks from the interns themselves, which were 6+1, and from the members of the training committee for any advancement or any corrections that we should take. And we invested a lot as a faculty in development of the e-portfolio, and we had a very great help, continuous help from Professor Ahmed Samir from the e-learning center all along the way. في كذا activity I will share with you later. I don't have to go through this again. Dr. Ahmed already did the workplace-based training and assessment, which was done by the trainers many times during the rotation and is expected to happen from the clinical supervisor this coming week, inshallah. It's not an exam. We are just making sure that he is taking baby steps in developing his skills that we need to make sure he's entrusted to do. During the pilot period, we were able to conduct 3 to 5 assessments per rotation, and this is a big number. Online and FaceTime orientation, supported online video, and thanks to Dr. Soha, inshallah, يوم السبت, this coming Saturday, will be able to join a real face-to-face workplace assessment workshop. دكتورة سهى عزمتنا كلنا عليه, so we're happy to attend. This will be very useful, definitely. Direct learning, lectures, simulation, just as Dr. Ahmed mentioned. E-library on the Moodle by great support and help from Dr. Ahmed Samir. The intern, as per the program, has to complete 13 courses over the course of 2 years, and we added more. Why? Because we think this is important. We added a course on communication. We added a course Women, Health and Family Planning, and this was on suggestion of Dr. Walid Bassouni, coordinator in Upsingaini, and another on intermediate life support, not only basic and advanced, and this one on recommendation of Dr. Rimi Kabariti, who's responsible for this part. And I'm keeping it open because I think we'll still have to add more. And once we create the library, we have it forever. We have it for everyone. It will be a very big investment. Self-directed learning, Incision Academy courses, and the clinical key courses, these are supported by the Egyptian Knowledge Bank, and this is something which is very good. Clinical rounds, presentation, community service, anything that the intern would like to join and yani highlight it in his portfolio is an add-on, of course. This is a link to the portfolio if any one of you would like to have a look. And this is the proof that we are starting our e-portfolio, inshallah, in June. We couldn't be able to start it on March because of some technical issues, but inshallah, we're starting it the next rotation, which is the 2nd on June. For any intern to pass his rotation, he has to complete his portfolio, fulfill the EPA, the workplace assessment. There should be 2 very important reports, one from the clinical supervisor, making sure he's fine and he's entrusted, and one, a team observation report. Everyone who dealt with this intern is happy with his progress. His friends, his colleagues, the nurses, the administration, everyone is happy, and this is part of working in an interdisciplinary approach. Our situation now, we are in week 7 in the first rotation, the re-rotation that started in March. We did workplace-based assessment twice, and we had a very good feedback from the interns. They're happy that someone is looking after them and making sure they are doing some progress, even if this progress was very slow. Incision Academy courses are ongoing. The clinical key courses will start next week. E-library, hopefully, and please, Dr. Ahmed, support me in this, we're starting a soft run on the 15th of May, and with continuous addition to the e-library, inshallah. We did something. Dr. Soha encouraged me to do this. I was very afraid. We did a mid-rotation e-survey to look about how satisfied and how happy or unhappy the interns are. We are in the process of analysis because we had this done on the 20th of April. كان نفسي يبقى معايا results, but the very quick look at the results are not bad at all. They're very encouraging. And they tell you that even the very small steps, the very little, the very small efforts that you do are very recognized by the interns themselves. They feel that someone know about them, someone listened to them, and this is very good in itself. We established communication channels, direct communication with the supervisors, coordinators. I make sure continuously that everyone knows his supervisor, knows his trainer. I'm there most of the time, so they know me, Director of Administrative Affairs, because big problems arise from the administration. Dr. Mohammed Nazmi is very cooperative on this. And of course, a huge e-learning support. Dr. Ahmed معاهم على WhatsApp, على Telegram, everything, but this is great. We also created e-communication platforms, Telegram group, WhatsApp group, incident report pathway. Dr. Dina مش هنا, but this was her advice. And although it's شوية overwhelming, but it's good. It's very good because it let me know about what's happening في حتت غريبة. Okay, and then we have an intern representative in the training committee upon advice of Professor Dr. Soha. Again, this was a little bit new to us. Everything is new to us. But they attended with us the last meeting, يوم الاثنين اللي فات, and they were very happy that we listened to them. Although, by the way, and this is a closed conversation here, they had 3 concerns. None of them was answered because they were not valid. They have to sign, they are in and out, البصمة, they want this removed. No, I will not remove this. They want to increase their the incentives, المكافأة اللي بياخدوها. It's not in my hands. But also I didn't really give them solutions, but they were happy that someone was listening to them. Thank you for this suggestion. This is new to all of us. So we know that there are challenges, but we try to view them as opportunities. The resistance of the faculty, and believe me, the resistance from the interns is more. Because they enter this internship year with the heritage of, I will do nothing in this year. I will go to Sharm el-Sheikh, I will finish the PLAB, I will finish the US Emily. I'm free now. There are more resistance from the interns than the faculty. We try to think of incentives, of raising awareness, of continuous feedback and evaluations. So hopefully this will help. The number of interns in Ain Shams University is overwhelming. We have like over 700 from 5+2, almost 900 from 6+1, and we deal with them both the same. They are all graduates of Ain Shams University. It is a big number. So we're trying to see the opportunity in capacity building, creating more trainers and supervisors. We'll try to see the positive side here. Again, the problem with assessment, providing more professionalism and faculty development is also something good. Commitment to intern training in Ain Shams University Hospital, we view this as a priority. It's not an option. We're committed to the internship training because this is our future wealth. This is our future wealth through a structured program, mentorship, hands-on training. على فكرة أنت كنت مديني 12 دقيقة وأنا كان عندي 15. But that's nothing important. It's okay. I'm just done.
We will give you the remaining 3 minutes.
I'm done. Feedback, assessment. This is all what we're looking for. Hopefully, next year, maybe, if I'm still there, I will tell you more progress, inshallah, on this internship.
We're
program.
waiting for the
Thank you very
feedback.
much.
Thank you, Dr. Marwa. Thank you. Okay. Okay. دكتور
اللي جايه دي احنا جايبينها من اليوكي عشان تقول لنا التريننج بروجرام عندهم ايه. قعدت معانا شهر هنا وشافت الدنيا انجليزيه. لا حضرتك اللي تقدميها.
Okay, we open the floor for the questions, starting by Dr.
Hi, Professor Marwa, where are you? Professor Marwa, hi. Lala, stay at your place. I want to thank you for this is very nice presentation. I'm worried about the final assessment. Have you any plans for the final assessment?
Final assessment per rotation. يعني احنا عندنا 2 summative assessments، واحد عند week 8 اللي هو ان شاء الله يعني الاسبوع الجاي، يمكن يتاخر شويه لان اجازه العيد لخبطت كل البلانز شويه.
What's the nature of the summative?
It's done by the supervisors, not the trainers. We have 3 forms of assessment till now. The direct observation of skills, the mini clinical exercise, case-based discussion.
Oh, very good.
Okay. يعني هو clinical supervisor, he will do one summative assessment at week 8 or 9, and then for those who did not do well in this, he can do another one 2 weeks after.
Yes. For example, for the tasks that are given during, for example, in cardiology, they have to learn how to practice ECG, echo, or
this is not
very
in the
simple
cardiology.
thing.
This is in the rotation of the internal medicine itself. They need to
For
interpret
example, if
the
they
ECG.
go to do the cardiology, are they going to be examined for how to make an ECG or how to read an ECG? Not make, nurse makes the ECG. How to read, how to
Yes,
interpret.
يعني هي it's one of their EPAs is to be able to interpret clinical data, and especially in the internal medicine, واحدة من the skills that they need to know how to perform and to interpret the ECG.
And the assessed,
Yes.
and to be
Yes.
assessed.
Yes, yes.
Okay, very good. Thank you.
Okay. Next question. We have many questions. Dr. Moa, and we'll give you next.
Good evening. It's not a question, but just a comment. I want to thank you so much for your informative presentation. You give us a very good overview and make us feel confident that our graduates will be more professional and more trusted.
Yeah.
So,
believe me, it's a commitment.
yeah. So thanks so much for the MI committee of Ain Shams University, and God bless all your steps.
Thank you very much. Thank you very much.
Thank you so much, Dr. Marwa. My name is Samira. I'm a previous 5+2 student and a current medical intern. I just wanted to thank you for all the effort that you've been putting, and we medical interns can see it. We can see all your work, and we really appreciate it. And we're happy to be also actively involved as interns. So my question is, how can we, as medical interns, be active in our own professional development without it being like a one-way type? Because you mentioned the roles of the clinical trainers and the supervisors and how they help us, but what do you need from the interns? And also, I have another question, which is, how can the leaders of the program help us achieve the professional behaviors and values beyond just learning the procedural skills and the clinical skills? How can we be more professional, and how can you teach us that? Thank you.
Okay, thank you, Samira, very much, and thank you all. Let me tell you that your trainer and supervisor and everyone in the program can help you if you have clear learning goals. So if you look at the first slide I put with the 11 roles of the medical interns, one of them is the intern is responsible for setting his own professional goal. So if you have your goal clear and you negotiate this with me or you reflect this to me, I can help you set the plan. I can help you with feedback. I can highlight your strength point and the points that need more progress and development. So I can help you if you have a plan in mind, or even try to make it less blurry to you. So that's how I can help you. How can you learn from your supervisor and trainer? Shadow your supervisor and trainer. And I'm sure that all of them, they have something to tell you. Yani I always believe that being in this place, Ain Shams University Hospital, is a huge advantage to learn, even if you don't if you don't have this great will to learn. You learn by diffusion. You learn by observing everyone around you. And a very personal comment, you're a very good intern, ya Samira. You don't need more development. Yani, mashallah, you're very good.
Thank you. Can I add just one suggestion?
Yes, please.
I heard you talking about the importance of reflective practice
Yes.
and reflecting and how that's part of the
Yes,
portfolio.
yes.
I feel like many of us interns have never really been trained on how to do that. So if there is possibly a reflective practice workshop that could be organized for us, I feel like that could be very helpful.
I think we can add this. Thank you.
Thank you.
Thank you.
So we ran out of time. Sorry for that. Let's move to our next presentation. Cultivating a Transformative Educational System for Growth and Innovation by Professor Sarah Walker. Yeah? No? Senior Registrar. Okay. Thank you.
Hello. In my last year of training, so thank you so much for having me here today, and a big thank you as well to Professor Amro El-Husseini, who kindly, back in November, helped organise for me to come out to Ain Shams University to be in the obstetrics and gynecology department, and this was an incredible experience. I learnt a huge amount, and it's amazing seeing how training is done in a different country and how much we can learn from each other. So if you're wondering about this title, the Silk Road is referring back to this ancient network of trades between countries where they exchange trade as well as knowledge. And talking about the Butterfly Haven, this is when you're thinking about medical education, how can we create the optimal cocoon for our doctors to learn and grow and be transformed so that when they're ready to fly and become butterflies as doctors. And I've created this model to try and illustrate as I go through the talk how when we're thinking about our trainers, we've got to think is what is our desired outcome at the end of the training program. Has this got a laser on it? And then you will have like the high flyer trainees who are at the top, and then you'll have the ones at the bottom who are just scaping through the training program. And I think this follows on well from the last two talks, really, because it's amazing what you're doing within with the medical students and with the interns, and this is kind of going more into the postgraduate training. So what I'm going to talk to you about is a bit about my Egyptian experience here, a bit about the UK training experience, an overview of the UK Royal College of Gynae training programme, some suggestions for joint development, and then my consultant, Mohammed El-Adabi, who cannot join us today, but he's going to talk to you virtually afterwards, talking about how training continues after training when you're a consultant, and the saga with that. So this is from an obstetric and gynecology perspective, but I definitely think all of these, this framework can be reflected into all specialities within medicine. So my Egyptian experience. While I was here, there were two standout features that I was really impressed by. One, the incredible surgical expertise, and second, the dedicated work ethic. I found that trainees who were at the same stage of training as me here, their surgical skills were just so much more advanced, and especially with the open abdominal surgery. And I thought, why is this the case? I think it's just you're very privileged here that you get an extensive case exposure, and also you work such long hours with your 24-hour shifts, and you stay within the university throughout your training that you get a real continuity of training experience. And what I was also impressed by was the educational atmosphere. I found that in theatre, you would often have the professors observing from the side while you'd have the lecturer teaching this junior assistant lecturer teaching the residents, and the whole time in theatre was just this purpose of sharing skills and knowledge, and there was no rush. It was all about education, and I thought that was really good. And then the other thing is the dedicated work ethic. So you guys work very hard. You do these 24-hour shifts. When you're residences, you don't have much of a social life, and yet I rarely heard the trainees complaining. And I think this is because you get so skilled and you develop so many good competencies that you come out as this, with all these skills as a doctor, and you have this real loyalty and appreciation for the university, which was really amazing to witness. So in the UK, The big difference is we don't work quite so hard. So our hours are quite different. And this came about because of this legislation, the European Working Time Directive in 1998. And it took some time to come in where basically they looked at hospitals and they were like, how can we make it safer, not only for the patients, but also for the doctors, because they were burning out. There was mental health and suicide and things like that. And so they limited the hours that we can work. And then now, really in 2016, the law is that doctors are not allowed to work more than 72 hours a week. And you have to have at least 11 hours rest in a day. And if you work outside of those hours, if something does go wrong, essentially you could not be supported in court against that. And then the other thing with the UK is the structured training program. So we have a really structured training program, which I'm going to share with you now. And the advantage of this is just that when you come through your 7 years of training in obstetrics and gynecology, you have this kind of accreditation, this stamp from the Royal College, where you know what you're getting within your trainees. And this is recognised all across the UK. You can go and work in different hospitals and you kind of know what you're expecting, but also you can go and work across the globe, which is amazing. And I think some of that can be brought in here because you're all amazing, but it just needs to be accredited a bit more for what your capabilities are. And so in Egypt, because you don't have such a structured program, I think the range of your trainees coming out of the university is much wider, whereas in the UK, because it's very structured, our range of trainees is much narrower. But within the UK, I'd say the bar within our desired outcomes, it used to be higher, and unfortunately this bar is coming lower. And I think what we need to think about in medical education is we always need to keep striving to keep that bar high. How can we keep improving how we develop as doctors and not to become complacent? So an overview of the UK training programme. It's similar to here in many ways. You start off with a 2-year foundation programme when you come out of medical school, which is very similar to your internship, where you cover 6 different specialities across medicine and surgery. And this is your foundation. And then you apply for your training number in your speciality. So obstetrics and gynecology is a 7-year training programme. And it's split into 3 main domains. Your basic training for 2 years, then your intermediate training for 3 years, and then your advanced training for 2 years, which equates quite similarly to your resident, assistant lecturer, and lecturer. And then there's big waypoints, and to progress from one stage to the next, you have to have passed your Part 1 membership of the Royal College of Gynae to go from basic to intermediate, and then you have to have passed your Part 2 and 3 to go from intermediate to advanced. And then we have this training matrix, which is a big spreadsheet, essentially, with various requirements that you have to achieve every single year, otherwise you do not progress to the next year. So like I say, you've got the exams, you have some surgical skills you have to complete. We have to get feedback from at least 20 members of the multi-professional team every year, showing that you're a pleasant, nice doctor to work with. And then also you have to do various courses each year. And then this is our electronic portfolio system, which is similar to what you were saying you're developing for the interns, where we evidence everything that we do. And there are 40 main domains. The group here on the left is the generic professional doctor requirements, which the Dean was talking a bit about in his talk, which is a big emphasis now in the UK and probably where the bar within our training has got a lot higher, and it's focusing on things like leadership, education, research, how you are as a doctor working within a health organisation, all the clinical governance and things like that. And then on the right here, these are the specific things to your speciality where potentially the bar has got a bit lower within the UK. How we evidence this, as mentioned before, it's exactly the same with the medical students. It's through doing case-based discussions, it's through sending tickets to your supervisors for them to feed back to you to deem whether you're competent or not at various skills. And then it's a lot of reflective practice, which we all love. And then we have a list here of surgical requirements that everyone has to be independently competent at by the end of their 7-year training. So it's not an extensive list, but you will know that every trainee who's done obstetrics and gynecology in the UK will be competent at these skills. And then in those last 2 years, in your advanced training, that's when you pick 2 areas that you're more interested in to then require more skills in those. So if you do pick something like benign gynae or gynae oncology, you will be doing much more procedures within that. And then what we do have is we have educational supervisors. So we have a consultant assigned to us who you meet with about 3 or 4 times a year, who just makes sure, that you are keeping up to date with your, keeping up to date with your portfolio and pointing you in ways that you can improve that. And then a panel of a range of consultants meets up and they assess your portfolio, they assess you as a person, and they deem whether you are suitable to progress to the next year of training. So you have 4 possible outcomes from this meeting. Outcome 1, where you pass and you progress the next year, to outcome 4, where you fail and you are removed from the training program. The other key part of our training is we have regular simulation training. So this is for every speciality. There's different types of training, and we have to do this every year, mandatory training, and if not, you're deemed not safe to work as a doctor within the UK. So 3 suggestions we've come up with for further development to implement here potentially is bringing in a training matrix to postgraduate training, bringing in a portfolio, and regular simulation training. So when you're thinking about developing a matrix, this is just some suggestions from what I observed here, is you think of your desired outcome and then you go back to the beginning, like you're doing. It starts with medical students, it starts there, getting used to this way of practice, and then you think, what do we want our residents to do, what do we want our assistant lecturers to do, what do we want our lecturers to do, and then you get that desired outcome, that doctor at the end of it. And this is just an idea. You'll have various skills you want them to achieve at each level within obstetrics and within gynecology, and then you bring in other things like ultrasound, courses you might want them to do, audit, exams, leadership management roles, and how you then bring that into a matrix. And then when they've completed, you know that you've got this trainee, this butterfly, this stamp, that they are capable of various competencies, and they can go and work anywhere in the globe. But what's beautiful is everyone is different, because you develop niches and you develop certain skill sets specific to yourself. And then a portfolio, so like you mentioned before, is just having somewhere where you log things. I noticed when I was here that people do all sorts of things. You get involved with teaching, you do presentations, you run conferences like this, and yet there's not really a portfolio where you're keeping all of this. And it's just an idea to start collecting this stuff. Like, for example, we have certificates for courses we do, certificates for e-learning you do, feedback from patients, conferences you present at, leaflets you might design, guidelines you do, research you do, and then this is all collated in a portfolio, and then it's evidence, so that when you come to that application for that consultant job, you can just fall back on this and you've got it all in your portfolio. And then potentially bringing in some kind of educational supervisors, so having a professor assigned to each trainee who they can meet with once or twice a year to see how they are keeping up with their portfolio. And then finally, simulation training. So you've got this amazing simulation suite, which I got to look around, but talking to the trainees, I think throughout their training they've only done about 1 session of simulation training. And there's a lot of evidence out there that what makes maternity units safe is by doing regular local multi-professional training. So we are lucky in Bristol that Prompt, which is an obstetric-based multi-professional training, did originate here. Prof. Tim Draycott set it up, and I think he has actually visited you out here. And the outcomes of doing this regular training were so good within our hospital and then across the UK that he has now taken it globally to several countries. And he is keen to come and bring it here if anyone's interested. But anyway, it has shown research that it's had an impact on reducing brain injury in babies, bringing down maternal death, and saving massive costs in litigation. But the key with simulation is, it's not me coming here and saying this is what we do in the UK. It's looking at your own units and thinking, how does your unit run when outcomes aren't so good? How can we run this better? How can we fix it? How can we make it safer? And then sharing it with your colleagues and practicing it, doing regular drills and simulation to ultimately improve patient care and patient outcomes. So that's the conclusion. Thank you very much. So now Mohammed El Adabi is going to do a presentation, if this works.
Okay. We postpone this presentation. You have Dr. Mohammed online?
Yes.
He's now online?
He's online, yeah.
Hello, everyone. Can you hear me?
Yeah, we can hear you. You can start.
Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. Good afternoon. My name is Mohammed Loudebi. I work as an obs and gynae consultant in Southmead Hospital, and I'm an honorary clinical lecturer at University of Bristol. I'm an Ain Shams graduate by background. I'm very grateful for Professor Amr for inviting me to do this talk here, and I sincerely apologize for not being there in person. I will aim to build on what Sarah has presented already and talk about training after becoming a consultant. As humans, it seems that we are conditioned to work towards goals. We all remember when we were trainees how eager we wanted to finish our training or finish the MD exam. But training doesn't stop at this point. And without having set goals and direction, confusion and bewilderment might set in. So what is next? As Jonas Salk, the famous virologist who developed the polio vaccine, once said, the reward of work well done is the opportunity to do more. And I'm going to share with you in the next few slides the UK's framework for professional development after becoming a consultant. The basis of the framework is the Good Medical Practice document, which is a document that is produced by the GMC. The document sets out the professional standards and behaviors expected by all medical professionals. It's a 28-page document that has 4 pillars. The first pillar is knowledge and skills in development. The second is the relationship between medical professionals and doctors. And the third is between medical professionals themselves. And the fourth is is maintaining trust in general. There are 2 main tools for further development for consultants. One is appraisal and the second is revalidation. So appraisal is an annual process by which each doctor has a session with a colleague who's trained for appraisals each year to reflect on their practice in the previous year and to plan for the future year. That is using the 4 pillars of good medical practice, aforementioned. During this appraisal session, an outcome is reached where it summarizes the whole appraisal. And this outcome is saved by the hospital or the trust. And then the second tool is the revalidation, which is actually a process by the GMC to ensure that all registered medical professionals in the UK can retain their license to practice. It's a process that happens every 5 years. And a medical officer, responsible officer, usually the medical director of the trust, reviews the appraisals from the 5 previous years and then reaches a conclusion and sends a recommendation to the GMC whether a doctor should retain their license to practice or not. The reason why revalidation was introduced was to bridge a gap in trust that had developed after a series of scandals late in the last century. This was to change the approach of the GMC to a proactive approach rather than a reactive approach. So with the revalidation process, the GMC assures that everyone is fit to practice rather than waiting for a complaint to investigate fitness for practice. One of the important components that for development that is planned for and measured is CPDs, or continuous professional development. In short, it is any activity that contributes to us learning, whether that's attending a course, a workshop, or even reading an article. As opposed to trainees, consultants have a responsibility to plan for their own CPDs, to identify those CPDs and to attend courses for them. Organizational support is key and mandatory. So in the UK, in a standard contract, 10% of the consultant's paid time is safeguarded for professional development. CPD is measured in units of hours. So 250 hours are required for a 5-year revalidation cycle. CPD can involve, and as Sarah mentioned, mandatory training, which could be generic or could be specialty specific. As you can notice here, not all of it it's more generic things in this slide, like safeguarding and fire safety, things that we don't necessarily have in Egypt. So what are the barriers for continuous development after becoming a consultant? I've listed a few, I'm sure you can list some more. Some of them are the lack of a framework and direction, the pressures, whether it's time or cost, the lack of a culture that nourishes and supports professional development. After mentioning the barriers, I'd like to give you an example of someone who's been very successful in their professional development to the point that they've shifted their career almost entirely. Mr. Sanjay Vyas, who's a retired consultant of obs and gynae at Southmead, where I work, started his career as a fetal medicine consultant. He actually has been very successful and has written one of the main papers in that field. Due to personal and professional reasons, he wanted to shift his career and shift his focus towards laparoscopy. And by the end of his career, he was the president of the British Society of Gynecological Endoscopists and has written the guidelines for the training program for laparoscopy training in the UK. Mr. Vyas has retired, and this picture is from his retirement party. But when I talked to him this week about this presentation, he wanted to make sure that the messages come across, that it wasn't just his own efforts that resulted in him successfully being able to shift his career and continue his development, but rather was the support of his colleagues and the management. All the talks that have preceded me have been very exciting and show that we're in an era of change, and change in itself is very exciting. There are a few questions that we ought to ask ourselves. Do we need to find a framework? Does Egypt need to have a framework for professional development after reaching a consultant? And if that's the case, who should lead on this, whether it's the university or anyone else? And what would be the uptakes and barriers for such a development? To say that this talk has been abbreviated is an understatement. Actually, we tried to jam in 2 talks in the space of 1. So I do apologize if this has been too quick, but if you want us to expand on any of those points, those are our emails. Please do get in touch. Thank you so much.
Thank you, Dr. Mohammed, for your presentation. Do you have any questions? No, do you have some?
Hello, Professor Mohammed. I'm going to present Dr. Sundus from Imperial College. Maybe her talk will be similar to yours. If you want to share, I don't know how, but could he share with us?
I don't know.
I'd be very happy to help in any way, shape, or form. That I think is the main aim of this talk, is to try and.
Thank you. Okay. When we connect to her, we connected to Dr. Sundus?
Yes, I'm here.
Hello, Dr. Sundus, how are you?
I'm fine. I can hear my echo.
I'm
in the
Professor
room.
Daya, how are you?
I'm well, thank you.
I want to present Dr. Sundus Hassouna, is a senior teaching fellow in public health in the Department of Primary Care and Public Health at the School of Public Health at Imperial College. Her research focuses on health policy evaluation and health system research with a particular focus on health workforce. Thank you for your presentation in advance. You can start, please.
Thank you, and thank you for the opportunity to be amongst you and to proceed to follow such incredible talks. So I'll try to share my screen. I'll need eyes on the ground to tell me whether this is working. Are you able to see my screen?
I can see it loud and clear.
Yeah, online, great. That's immediate feedback. Anything on the ground? Can you see it in the hall? I can't see thumbs up. So
yes, go on, please.
okay, fantastic. Thank you very much. And مساء الخير, and hello everyone, and thank you again for joining those who are online and in person. It's a pleasure and a privilege to be amongst you today and to share some of the work that I have recently led on
which explores the impact of health workforce policy interventions on physicians' performance. And I'd like to take a pause here and just congratulate those who have kind of constructed this session, because it all builds on so seamlessly onto each talk. And I feel like there will be many aspects of what I'm going to discuss in my presentation that reiterates and reinforces a lot of the excellent points that have been made earlier. So just by way of background, the work I'm going to share here specifically explores the linkages between physicians' validation systems globally and health workforce, and examines how such interventions can produce their effects. So again, hopefully resonating and reiterating a number of things that have been discussed already. This was drawn from a multi-method study, which was anchored by a realist-informed approach, which primarily utilizes a generative explanation for causation with the aim to develop relevant evidence that was translational to policy, education, and practice. I've primarily centered my presentation around two main themes, so the global physicians' performance assessment validation systems and some of the key concepts and features they possess, and the causal mechanisms at work in the health workforce performance evaluation process. I don't think I need to persuade anyone in this room that human resources for health or health workforce are the backbone of health systems. There's truly no health without workforce. Yet in many countries, including Egypt, the availability of a qualified health workforce able to deliver effective and equitable health services remains a challenge. This has prompted the introduction of a number of regulatory interventions globally to increase the productivity and the performance of physicians, which includes renewal of certification, relicensure, revalidation, which we've just heard about, despite actually notable absence of clear evidence regarding the effectiveness of such interventions. Nonetheless, health systems and countries around the world, including Egypt, have embarked on experimental regulatory approaches. In Egypt specifically, there's been fairly recently a formal body that's been created and mandated to lead the development and delivery of medical license renewal, so SEMTA, which has been absorbed into the Egyptian Medical Council. There are broadly three main objectives for professional regulation. These are to have a system in place to ensure professional accountability, to establish and ensure that standards of care are maintained at acceptable levels, and to promote better quality of care. And professional medical regulation can be traced back almost 4,000 years ago in the Code of Hammurabi, where standards of physicians' behaviors, accountability, and even detailed description of the relationship between practitioners and their patients, including fees, has actually been circumscribed. So this is not really new. What's new-ish, so over the past 2 decades or so, is the increasing awareness amongst regulators, practitioners such as yourselves, and to some extent patients, that the initial medical certification and licensure obtained at the end of specialist or residency training is no longer adequate to sustain quality of care across a physician's career. This stipulates that the once in good for life model really requires more thoughtful and well-structured approach to learning in order to promote practice and performance. The concept of physician performance was introduced in 1966 by Avides Don-Abedian to examine healthcare quality and the related attempts to systematically measure it with an eye towards improving healthcare quality. I'm sure many of you would be familiar with that. Physicians' performance, however, as has been mentioned in previous talks, is defined differently across the globe, which has led to little consistency in terms of not only how human resources for health strategies are evaluated, but particularly those related to individual level performance are monitored and evaluated. So once a clinician moves on from training and ventures into the real world of medical practice, measuring their ability to practice well or even safely becomes more complex. And some of the reasons for that have been discussed already. Just to quickly touch on these include the fact that the context and the environment within which physicians practice is quite dynamic and is influenced by a number of different and often conflicting variables. Patients often have complex needs, and the physicians only provide a portion of the direct care within a complex health and care structure. The landscape within which they operate is continuously changing and evolving, not only in terms of new illnesses emerging, but also new technologies developing rapidly. And finally, the majority of measures that, and again, this has been mentioned previously, the majority of measures that currently exist to evaluate individual level ability are measures of how individuals or physicians apply their knowledge and skill set, and almost all of which use traditional written and clinical observation methods in a controlled or simulated clinical environment. The past 20 years, though, have seen an emergence of a variety of validation systems across the world, all of which are essentially trying to achieve the same purpose of either keeping track of, officially documenting, and in some cases, improving the health workers' fitness to practice. And so within this fairly new territory of physicians' validation systems, evidence-based approaches for implementation actually do remain scarce. Causality is quite difficult to achieve here. And so unsurprisingly, various methods to validate physicians' performance can be seen across the health systems. There's also variability in the names and definitions used to describe these national validation systems, which range from renewal of licensing, relicensing, such as what Egypt is planning on embarking on, revalidation, such as in the UK, which was briefly mentioned, and recertification, each having or aiming to achieve a slightly different objective. In this work, we examined global physicians' performance validation systems, including the United Kingdom's national revalidation and appraisal systems, the US maintenance of certification programs, the Dutch recertification program, the Canadian maintenance of licensure program, and the revalidation program, as well as the Austrian, Belgian, French, German, and Spanish equivalent validation systems, which were all seen actually to primarily be geared towards strengthening mechanisms of professional accountability and accountability to the public. And professional accountability here is understood to be as accountability for maintaining and improving professional standards, while accountability to the public focus more on ensuring safe practice and the highest level of care provision. And the need for formalizing such mechanisms of accountability primarily stemmed from the global movement away from the historical self-regulation MO, modus operandi, that the medical profession has formally and informally operated for decades and still does exist in many places around the world. I don't really have time to go into detail about the underlying reasons and motivations for this global movement, but maybe to build on something that was said in the previous talk and to highlight that in some countries, the need for formalizing such mechanisms, such as in the UK, was more urgent than in others and took on a more social and political imperative. The tipping point in this context was high-profile malpractice and medical negligence cases, which really unmasked at the time the ineffectiveness of the regulatory mechanisms and the overall gross failure to uphold the standards of the profession and safeguard the public from harm. What we observed was that the nature of the regulatory approaches and schemes vary significantly across the countries as well. So this variation can be seen in the organizations responsible for regulating physicians and the degree of authority they have or they possess. In most cases, the main stakeholders or the regulators are either the professional medical bodies, so this was the case in Austria, in Germany, in Netherlands, and Spain, or the ministries or departments of health, such as in the case in Belgium or the UK, and the UK. However, in some cases, it may actually be the medical insurers, such as the case in Canada and the US, because they determine the requirements for physicians to be contracted with them. But more often than not, it was a combination of stakeholders that share the governance and regulatory responsibilities. The schemes and the methods we found in the countries that we examined could kind of be divided into two main categories. These are compulsory and voluntary. So compulsory systems, such as the one found in Canada, in Germany, in the Netherlands, in the UK, and in the US, require formal review or audit to be undertaken for continuous medical education and continuous professional development activities. And again, the previous talk touched on a number of these activities and how they're recorded. This is usually done on a cyclical basis, so within the countries that we've examined, ranging from 3 to 10 years, with the potential consequences for non-compliance. So I think Sarah was mentioning something about kind of potentially being removed from training. The same can happen on a consultant level in the context of the UK. But CME and CPD here encompass activities such as appraisals, workshops, peer, patient, and multi-source feedback, self-assessment and reflection. I think that's reflection is the word of the day today. Clinical audits, and in some instances, actually courses followed by examination. Voluntary systems, on the other hand, were primarily geared towards self-assessment and adopting a broad criteria for CME and CPD. So these systems were really seen primarily as based on activities to promote lifelong learning and professional development. However, they actually often lacked an overarching competency framework and included very limited, if any, components that assess the performance in practice or elements to periodically evaluate the physician's professional proficiency in the field. Examining the methods and interventions currently in place in the studies to regulate the physicians within national level programs, it was quite unsurprising to see that the theories and approaches we cataloged that informed the design and the delivery of these systems were quite intricate. So what we tried to do is summarize these within using the realist approach in a context and divvy them up into context, mechanisms, and outcomes and try to understand the relationship between them. So here I'll summarize what we listed and synthesized in terms of the context, mechanisms, and outcomes at play in the process of health workforce performance assessment as embedded within the physician validation systems that we in countries that we examined. So context here was defined as the background features or circumstances that shape the mechanisms through which the programs or systems work. The ones we've identified included the type of assessment, which includes methods and formats. So methods such as the compulsory or voluntary system that I previously touched on, and the format is can be seen in the form of the exams, the appraisals, the workshops, etc. The type of feedback. So this included the effectiveness and coherence of the feedback. For example, if there's high quality feedback that's received, so that's to say it's meaningful, it's specific, and it's timely, it's more likely that this will trigger cognitive dissonance and reflection within the physicians, whereas if feedback is actually superficial and incongruent, this can trigger denial and rejection. So again, this was touched on when there was a discussion around the portfolio and feedback program within Ain Shams. Physicians' response, this includes how seriously the physicians engage with the assessment process, which stems from the circumstances within which the assessment is undertaken. And it also includes the physician's capacity and capability to undertake meaningful reflection and purposeful behavioral change. And then finally, within the context, we identified supportive environment as a context, which basically includes effective information governance systems, for example, a health information structure capable of collecting, recording, and analyzing performance relevant data. And it also includes the availability of knowledge brokers. So these are individuals who can provide operational communication and liaising between the doctors and their employers, as well as the culture within which the regulatory intervention itself operates. So for example, whether it's one that is intended to catch doctors out, sort of saying, to discipline them, or one to identify poor performance early to improve and develop. The mechanisms we've identified, and here mechanism refers to the process that describes how the program or system produces change and explains its impact on the physician's reasoning and their choices. We've identified reflection, which is the process of critical, deep, and transformative personal consideration and deliberation, which can trigger profound cognitive and emotional changes. Self-affirmation, which refers here to the process of threatened self-image, which triggers affirmation of the integrity of self. That means that the person has a strong desire to uphold a positive self-image. Power dynamics, which is about shifting from professional autonomy to regulated accountability, which is quite difficult to achieve across health systems. And that often happens as a result of strengthened performance surveillance, which can trigger a feeling of being more scrutinized, and a reduction in the hierarchical differences amongst doctors. Denial, which is the process of refusing or refuting feedback and the data presented, triggering a complete disengagement with the process of evaluation and regarding it as irrelevant or invalid. Dissonance, which I briefly mentioned earlier, which refers to the discomfort or tension that stems from or originates from discrepancy between the physician's beliefs, attitudes, and behaviors that trigger change in those beliefs, attitudes, and behaviors to reduce this discomfort. And then finally, outcomes, which here refer to the mixed pattern of outcomes consisting of both intended and unintended, intermediate and final. So we've identified game playing, which is strategically manipulating the process to present themselves, the doctors, in a more positive light, and so not accurately reflecting true performance or ability. Tick boxing, which refers to superficially going through the motions of the process, lacking thoroughness, detail, and again, not accurately reflecting true performance. Behavioral change, which refers to modifying behaviors and practices and attitudes that foster a growth mindset. And again, that was mentioned previously, which can help promote continuous development and improvement. And then creating or improving personal development plans, which again has been mentioned in terms of a way forward, which really here refers to the development of or improvement of existing structured and individualized plans, which include identifying areas for improvement, specific goal setting, all of which support professional growth and continuous development. And then finally, obviously in terms of the final outcomes, maintaining performance, which refers to maintaining existing level of performance or improving performance as a final outcome. Distilling some of these connections and interactions between the context, mechanisms, and outcomes at play within the validation system, it was clear that a variety of connections and pathways can be observed, which is expressed here. I don't know if you can see my cursor, to try to make sense of some of these connections. So these interactions provide explanations for the different outcomes produced. So by that, I mean reasoning why interventions may or may not work, in what contexts, and in what ways, under which circumstances. So let's say for any outcome identified, whether final or intermediate outcome, which mechanisms or group of mechanisms could have caused it, and the context within which this mechanism or group of mechanisms was likely triggered within. So for example, behaviors that foster growth mindsets and achieve potentially behavioral change can ultimately result in improving performance. And this can be achieved if critical, deep, and transformative reflection is triggered within an environment that meaningful feedback is provided,
Dr.
and there's a
Saunders,
supportive
please,
environment.
a few minutes, 3 minutes.
Yes, I'm on to my last slide. So this is kind of just to make connections between some of these context mechanisms and outcomes at play in terms of the performance assessment process. This is definitely my last slide, which is where I'd like to include with some of the reflections and the learnings from this work. First, that physicians' performance regulation sits within quite a complex backdrop of relationship and interactions between doctors, regulators, and the context within which they operate. This is mentioned several times today, and I think is really imperative to consider when designing systems that are intended to evaluate physicians' performance meaningfully. So this warrants that the one-size-fits-all approach doesn't really work. And so while obviously it's important to seek out best practices and appreciate how different methods influence change, context specificity and context sensitivity is really important to address local concerns, needs, and cultures. It's also important to recognize and appreciate that the underlying motivations for physicians' performance regulations are multiple. So this includes professional accountability, accountability to the public, health system sustainability, and of course, efficiency and effectiveness. And so understanding these and leveraging them is also key when designing such validation systems. It's also important to remember that learning and development is a process rather than a discrete event, and this has been mentioned earlier in the discussion around the portfolio. It's based on and it requires cognitive, behavioral, and social scaffolding to galvanize the sense of agency in the physicians, to enable them to meaningfully progress in their careers. And lastly, physicians' validation systems and regulatory interventions used to attempt to quantify, and I use the word here attempt deliberately, and ultimately improve physicians' performance should be considered as one of the cogs in the vast machinery of healthcare quality improvement. And it's really, it's imperative that this is the health system boundaries within which they are situated is carefully considered. I'm terribly sorry I went over time. Thank you for your attention, and again for this opportunity to present amongst you. I'd be happy to take any questions if there's time.
Thank you very much, Dr. Sundus. I expected that you can give us an idea about the Egyptian status, but I could summarize it that the Egyptian Health Council has started a compulsory exam I think last summer, and they are going through the continuous medical education hours, and I think the Egyptian Health Council is sponsoring this conference. So this is a very good step.
I'd be really happy to elaborate on this if there's time, and kind of
yes.
Actually some of this work has been prefaced an assessment or a prospective assessment of the Egyptian.
Hopefully we could, after 5 years, we could start an exam.
Relicensing endeavor. And so there are multiple components within that, but I think the aim is to work towards a system similar to revalidation, primarily based on CME activities at the time, but I think this is evolving. But yeah, the Egyptian experience so far has been trying to utilize the systems that are already in place and trying to use the experiences in the evolving medical education landscape, but also adopt experiences such as those from revalidation in the UK, Canada, relicensure, to try to quantify physicians' performance within the span of 5 years. It's in its infancy, but hopefully positive vibes.
It's stepping. Thank you.
Yes.
Any comments, please, for the floor? Any questions? Okay. Thank you very much, Dr. Sundus. Thank you, Dr. Muhammad.
Thank you.